The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone. Welcome to our webinar today about evolving evidence, fake news, and emerging contexts, researchers at the nexus of evidence-informed decision-making for COVID-19. We will be starting quite shortly. Just hold on tight, and we will be right with you.
Welcome, everybody, and thank you so much for joining us today for this exciting webinar. Let's see if I can share my screen, and hopefully everybody can see me. Welcome. The objective of today's webinar is to discuss the role of African researchers in contributing to localizing the public health evidence and recommendations, and for understanding the fact that researchers are navigating competing demands, limited bandwidth to support the COVID-19 response, and challenges and opportunities for providing this evidence has sometimes been in conflict with the economy and social challenges. And we really want to hear from colleagues on the ground, researchers working with decision makers during this pandemic, to hear about how they're navigating this really complicated terrain at the moment. So welcome, everyone. So before we launch into our webinar, I'd like to just remind you of some housekeeping. Make sure we have some principles in place that will be helpful to you. So we ask that to keep your webcams and your mics off. Organizers will be managing this from our side while you're listening, but of course submit your questions to the Q&A box at the bottom of the GoToWebinar control panel. And you can submit your questions at any point during the webinar. The panelists and the presenters will collect the questions submitted by you during the session. You're also welcome to raise your hand during the Q&A, and we will unmute you for you to be able to share your experiences, but also to ask our panelists any of your questions. In case we don't get to all the questions, which sometimes happens, we'll try and get back to you later via email. And if you have any technical problems, please write to Nanuka at the address that you see here. And we will also be sending you a post-webinar survey at the end of this. So I'd like to first give you a little bit of an introduction about the two organizations that are hosting today's webinar. And Daniela, if I can ask you to also put your camera on. The Africa Evidence Network is a Pan-African network that's hosted by the Africa Center for Evidence in Johannesburg. The network has close to 3,000 members across Africa. And our members include people from and colleagues from the research community, the decision-making community, advocacy organizations, and NGOs, and anybody that's working at the nexus of evidence-informed decision-making. And it really has a mission to enhance, to provide a platform and to enhance discussions and deliberations about evidence-informed decision-making, particularly in Africa. There are various ways that the AEN engages with its network, with its members, similar to other networks, through webinars such as this, through blogs that are welcome to be submitted, newsletters, our social media platforms like Twitter and LinkedIn. And we also have every 2 years, the Africa Evidence Leadership Award for upcoming leaders in evidence, and much, much more. There's information on the left side of the screen on how to stay in touch. And towards the end of the webinar, we'll also give you some links about how you can join if interested. The other host for this webinar is the Translating Evidence to Action Thematic Working Group from Health Systems Global. And I'll ask my colleague Daniela Rodriguez to give us a quick update on that particular thematic working group. Over to you, Daniela.
Thank you. Hi, everyone, and welcome. We're so happy to have you here in our webinar. As Nasreen mentioned, the other co-host of this event is the Translating Evidence into Action Thematic Working Group. We are one of 10 thematic working groups that are part of Health Systems Global, which is the International Health Policy and Systems Research Society. And our thematic working group is focused on the translation of health systems evidence into action through knowledge exchange and practical guidance. And our main goal is to decrease the gap between what we know works and what ends up happening. And as you can see listed here on this slide, we have a few different objectives. One is around enabling researchers to support health systems research awareness with other stakeholders in the space, but also raise the importance and value of evidence and create opportunities for dialogue and best practice sharing. And one of the ways that we do that is we have a listserv for a thematic working group where our members share experiences, ask questions, and in general try to form a network and a community where we can communicate with the successes and challenges that we're facing. And as you can see here, there are different ways that you can join us, and we would love to have you if you are so inclined. Thank you.
Thanks, Daniela. It's really exciting to have this kind of collaboration between two organizations that are so passionate about evidence-informed decision-making, both on a continental as well as a global scale. And with the Health Systems Global Thematic Working Group in particular, it's very much focused on health policy and systems research in the field of public health, which is really the focus of today's webinar. So it's nice to have this. So as we move ahead to in the webinar, we would really love to involve all of you to the extent possible. We all have different experiences about how we're addressing and experiencing the COVID-19 pandemic as researchers and as decision makers. And so we thought we would ask you for your perceptions and impressions on three particular questions that we're keen to hear your feedback on. So Nanuka is going to launch the polls and the three questions, and please do participate and give us your answers, because I think it'll be really interesting even for our panelists to reflect on your answers and give you a chance to speak with us at the end as well about why you're experiencing things the way you are. Thank you, Nanuka.
Thanks, Nasreen. So we've got 20% of attendees participated in the poll already, 40%. Thanks, everyone. Few more seconds and we will close the poll and share the results with you on the screen. Thanks, everyone. Here we go. Nasreen, over to you. Here we have the results of the first poll.
Unfortunately, I can't see the poll results. Nanuka, could you read them out for us?
Of course. So 97% responded true and only 3% responded false on the questions that we have asked to the audience.
Okay, and that's, do we have different different responses for the 3 different questions in terms of how many true and how many false for each of the 3, or was that just the first question?
That was just the first question, so I'm happy to launch the second question right now. Great.
Okay.
Here we go. So evidence has become more controversial as a result of COVID-19. So you have 2 answers here to select, true or false. We have 88% for true and 11% for false. Great, almost 80% of our attendees have participated. Few more seconds, and I will close the poll. Great, thanks everyone. So the 83% marked true and 17% marked false, and I hope everyone can see the results that are shared on the screen right now. And if you permit, I will now launch the final poll today.
Perfect, thank you, Nanika.
So the poll question is on the screen. Please participate, mark your answers. Thank you, everyone. So the question was, the public health evidence has been attacked in favor of other forms of evidence to address the challenges of COVID decision-making. So 81% responded true and 19% marked false. Here are the results. Thank you, everyone. Nasreen, over to you.
Thank you, Nanika. Thank you so much, everyone, for participating. And it's striking to see the leaning towards the truths in all cases. But I'm very curious about those who actually don't feel that's quite the case, and perhaps from their experience or from their context, whether these situations are actually playing out very differently. But I think the fact that we have a variety of answers and people from a variety of countries on this webinar goes to show that that there is definitely a momentum in terms of the role that evidence is playing in decision making, in terms of the demand for it, but also in the way that it's being used, either positively, negatively, but also in terms of what other evidence is being demanded from other sectors, even though this is first and foremost a public health emergency. And I think we've seen that in all the countries we live in, that there are many other factors from the economic and even education and many other sectors that that sometimes aren't necessarily at par with what we're seeing needs to be done from a public health perspective. And so it would be great if you felt like you would like to share your thoughts and opinions in the chat box about why you answered the way you did. In the meantime, hopefully we'll be able to hear in detail from the 3 panelists that we have today. And I'm going to go ahead now and introduce each of them. Our first speaker is Dr. Ronami Jumbi. She is a health policy analyst, an epidemiologist, and a research scientist based at Makerere University in Uganda. And she's the current director of the Center for Rapid Evidence Synthesis. She has a special interest in the use of evidence in policy and decision-making processes, and she actually leads a team of researchers developing and evaluating rapid response mechanisms to support policymaking in Uganda. She has also been very involved in contextualizing evidence for the COVID-19 response, not only in Uganda, but also in the region. And she's a member of the task force of the Uganda Medical Association, ensuring that all healthcare workers in Uganda are equipped with personal protective equipment to avoid contracting the virus and being infected. So lots of engagement here, both from the researcher side, from influencing decision makers, but also more at the where the rubber hits the road at the coalface with health workers. So thank you very much, Rhona, for joining us today. And if you could put your video on so we can all see you and keep it on, that will be great. Our next speaker is Dr. Benjamin Sc Uzochukwu, and he is a public health physician at the University of Nigeria Teaching Hospital, Enugu, and a professor of public health in health policy and systems at the University of Nigeria in Nsukka. He was the founding director of the Institute of Public Health there as well, and has worked across the region with WAHO and ECOWAS on various initiatives over the years. He is also the founding and executive member of the Association of Schools of Public Health in Africa. And at the moment, he is a member of the Ministerial Expert Advisory Committee for the COVID-19 health sector response in Nigeria. So it'll be very interesting to hear from you, Dr. Uzochukwu, about the experience as a researcher directly being on an advisory committee to the government. So welcome, Dr. Uzochukwu, and if you could also put your video on so we could see you, that would be great. From Ivory Coast, we welcome Professor Mamadou Samba. Professor Samba has been the Director General of the Ministry of Health since March 2019, and the Director of Planning, Evaluation, and Health Information for the Ministry of Health for over a decade now. He also led the drafting of the 2010 and 2015 reports on the MDGs in health, and he is, while the General Coordinator of the COVID-19 pandemic response at the Ivory Coast, he also is not only a policymaker, but also an academic and a lecturer in public health and health economics, and a researcher at the university in Abidjan, Cote d'Ivoire. So welcome, Professor Samba. Welcome all of you, and I hope we can see all of you with your cameras being on. So I've placed the topics that we're going to discuss on the screen in the event that we have other non-English speakers or those that speak English as a second language attending this webinar. And in case I speak too fast or in case you can't understand my accent, please note that at least the main questions to the panelists are posted here for your perusal. So in terms of my first question to the panelists, and if you can share with us a little bit, as we all know, and as we're seeing from the polling questions, the ecosystem around evidence-informed decision-making has been growing steadily in Africa over the years. And we've also seen more individuals and organizations focusing on the art as well as the science of EIDM. We're seeing more and more that governments are paying attention to evidence for their policies and decision-making, and this seems to have been accelerated both positively as well as negatively during COVID-19. So if I could start with Rhona, Dr. Mijumbi, could you perhaps tell us how your country, how has Uganda approached tackling COVID-19? And more importantly, maybe share with us the role that you are playing and other researchers and African colleagues are navigating to localize the public health evidence for COVID decision-making. Over to you, Dr. Mijumbi.
Thank you, Nesrin. And a good afternoon, good morning to all those who've managed to join us wherever they are. Tackling your question, how Uganda is approaching the COVID-19 response, I would first proudly say Uganda can be deemed to have been one of the successful ones, at least so far, going by numbers of cases and fatalities. We have had the benefit of watching and learning as the pandemic, spread in the West and in Asia and elsewhere before it came to the African continent. And I think that's really important that you would watch and learn, It has been very helpful. So we were able to learn and take notes, picking up both, published and unpublished evidence on what seemed to work and what did not. And this has guided most of our response. And so if we were picking up what others were doing, what made a difference, because some of the ones we learned did not have a very successful outcome, others did, but we quickly picked up what we thought was helpful. But what made the biggest difference, because you'll find that we have, say, similar responses that others have taken as well. But I think what has made the biggest difference with Uganda is that the decision making we have had has been very quick, keen, and definitive, with decisions being made on how to manage different aspects of the epidemic done, I think, at very critical times. As soon as it was clear that there was, that this was becoming a pandemic, and so sooner than later it would come home, the authorities were working very closely and preparing, such that we went ahead to actually institute certain measures before we even had our first case identified in the country. We know that the timeliness of decisions has been very key in ensuring a difference in outcomes. Two countries might have had the same decision, but their timing made all the difference. Sometimes the difference of days in making a decision meant the difference in fatalities of thousands of lives. So Uganda's timely decision-making, especially at the beginning of the epidemic, made a very big difference. And then following those world events and doing a lot of analysis on what it actually means for us, both from the published rigorous evidence, but also from the informal evidence, Uganda has really relied a lot on the decision. So you will note that each of the 30-something interventions that we have put in place that form, the holistic response package, they're all grounded in some sort of evidence or some proven strategy, either from experience with epidemics, we've had to handle some before this, or from earlier experiences of other countries, or from, the earlier experience from, countries that experienced the pandemic before us. But Uganda has really heavily relied on listening to or getting input from scientists and experts. And we're fortunate enough to have had that past experience, that people have also been calling on us to draw from the experience that we've had with past epidemics, like Ebola. And that has also helped in the fact that the public is also well versed with some of the practices that, washing your hands and, keeping that distance and disposing or taking care of funerals. Some of that experience has already been in place and the public sort of has an idea. So a lot of that evidence has been incorporated and has helped the response in the country. Now, the measures have been instituted in an incremental manner, but there's a lot of analysis that goes on. So for example, the very first measure included a lockdown of the borders. It was clear that the cases that our neighbors were, a few of our neighbors had cases before we did, but it was clear that those cases were being imported. And so we quickly categorized the countries that we thought, might be a problem. So we had several categories, and there was the category 1 countries, where if we knew you were coming from those countries, we quickly quarantined you and tried to, follow you up. But even that didn't take very long. We just decided to close the borders and paid more attention to those last flights that came in. And indeed, on those, we picked our first case about 3 days into closing the borders completely. So again, getting that information as it was coming in, studying the situation and knowing. So although there were questions on whether indeed this was the index case, might we have missed, earlier cases because we're not testing widely yet and we're relying on temperature monitoring at border points. But we now knew many of the patients, and now we know that many of the patients are asymptomatic. So it's possible that we might have, missed the real, index case. But even then, this gave us a place to start with the evidence that we had at the time. And then things like the lockdown, now the lockdown may be criticized in so many ways, but I think it was very important in contributing to Uganda's low number of cases. Again, in this, we were sort of using past experience. While many countries used it to slow down the spread of the infections, easing the burden on the system, and also buying time as you prepare for what might be worse situations eventually, Uganda, in addition, used it to monitor the picture in the country. So the president explained to the public that, using his military experience, he gave, a military illustration that when you're in battle and you are in enemy territory or you suspect they're somewhere near you, your commander will usually ask you to stop moving and listen. In that way, you're able to work out which side your enemy might approach you from. It is the same thing. It's the same thing here. So during the lockdown, we were able to monitor and work out and zero in on which category was actually bringing trouble. So we're able to zero in on the truck drivers as a group, you know, the truck drivers that go across the border, you know, taking goods and all sorts of things. We were able to zero in and see that these were a particular group that was becoming trouble. So indeed, most cases that we have had are in one way or another related to truck drivers. There are many aspects of the response. I could go through all of them, but you know, we can save time. But to make the case that generally the response has been characterized, one, by quick and timely decision making. You could have all the evidence in the world, and I think many of you know, some of the countries that we know had good enough evidence on which they could make decisions, but the timeliness might have been trouble. And then reliance, or at least giving a great consideration to evidence and different kinds of evidence. This could be research, it could be the rigorous research, it could be your peer-reviewed research, and we can see how much that also, you know, came under attack or under scrutiny. I won't even call it attack. I think it's been more scrutinized in how it actually informs what we're doing. So a great reliance on that experience and science has also been very important. And so how have researchers come in to help localize a lot of this evidence for the decision making? You know, the evidence has been present in multitudes. I don't think, I mean, we do have policymakers with us, and I think they can attest to the fact that there's been a lot of evidence, a lot of it quickly changing, and a lot of it coming from multitudes of sources, packaged in all kinds of modes, you know, technical modes. And a decision maker at any time might have felt, you know, a difficulty knowing what to go with and what to leave behind, both technically, but also contextually. So we are learning from other places, but how do I put it in context? So we are seeing lockdowns, you know, being done in Asia in all sorts of ways, but how do I context that for my, how do I put it in my own context and see whether it works? So researchers and knowledge brokers in Uganda have been at the forefront of this response, responding to the needs for decision making. They have been looking at the available evidence and contextualizing it for our needs. So for instance, the Center for Rapid Evidence Synthesis has had the task of looking at the already available evidence, but then putting it in the context for the Uganda, you know, situation. And then other researchers have been looking at what is happening elsewhere and then modeling. So taking us to the front. So what we know now is this, but what does it mean, you know, for our future? What, you know, if we model, what is it going to look like for ourselves? And then others are actually doing empirical research to inform what we know is now an ever-changing, you know, response. So we have a community survey, a rapid assessment survey going on constantly to see what is changing in the community. So a combination of this is actually coming in and helping to inform the Minister of Health and the President and everybody who's trying to make all kinds of directives and decisions. And it helps to keep everything up to date. You'll find a number of task forces that are all supporting the response. So for example, we have the National Task Force, and then we have smaller task forces that are feeding into that National Task Force. So for example, we have the Uganda Medical Association having its own task force and making small decisions, which then go in to feed, especially because the Uganda Medical Association is, you know, mandated with the welfare of doctors. So they're concentrating and making sure that that is taken care of. But again, making sure that this is aligned with the evidence that we know and making use of the researchers in the country. So, and researchers have had to quickly adjust as things happen. The decision-making process has been at a very high level, and being able to input, I think many researchers and knowledge brokers have had to learn quickly how decision-making is actually made and then trying to interact with it. I think I'll give a little more, you know, information on that a little later. In the interest of time, I'll leave my colleagues to probably say something about this as well.
That's great, Rhona, and it's really wonderful to hear that there's been a great reliance in some ways on evidence to inform decision making, but that obviously there's an overwhelming amount of evidence, and not only that exists, but that's constantly being created as well. And you mentioned many different kinds of inputs, from syntheses to modeling to primary empirical research and surveys, and all of that to feed into very quick decision making is probably quite a complex situation in the pandemic that we're in right now. And I'm wondering if I can go now to Professor Uzochukwu to reflect on how similar or different you're experiencing this in Nigeria. I know that you sit on a ministerial advisory committee and you meet every Thursday. And it would be lovely to hear what is the process for decision making, particularly in your context, and in reflection to the role of researchers to contribute to that decision making and providing the evidence. So over to you.
So thank you very much, Nasrin, and welcome to the webinar, everybody. Good morning, good afternoon. I'm sure some people are also sleeping. Good night. Good evening. Okay, so I really envy the Ugandan case, because in Nigeria, the main problem we had initially was slowness in taking decision. And this was actually very surprising, because we had Ebola 2014, and we have evidence there on how we tackled Ebola in 2014. So one expected that to have been re-engineered, and then taken on board to deal with the COVID-19. But that was not so. So we had this issue of timeliness of decision making. It took the government, for example, time to lock down the international borders. It took the government time to even make a public announcement to reassure the populace about the impending pandemic. So all the things that we were doing at that initial time was like panic measures. However, like a month into the discovery of the index case, the government started using evidence. And it was actually as a result of professional bodies, coming together to complain and to begin to volunteer themselves to work. And so the first official move was the establishment of what we call the Presidential Task Force, which is the national making body. And what I like about the Presidential Task Force, technically, is that the head of that Presidential Task Force was a politician very close to the president. So issues about decision and the president getting the ears of the Presidential Task Force was very, very easy. So if you had put an actor that was not properly known by the government, by the president, then it would have been very difficult to make decisions, quick decisions. So from that point, the government started, making decisions with evidence. After the PTF, then there was this Ministerial Expert Advisory Committee on COVID-19 health sector reform that was established by the Minister of Health. And that committee assembled mainly researchers from the academia, professors of public health, virology, health economists, respiratory physicians, and all other related people from the National Academy of Science. And that committee is headed by a world-renowned virologist who has participated fully in polio eradication and other disease eradication, Professor Tomori. He's worked with WHO. That was when we started synthesizing evidence and started advising the minister, and the minister takes the advice to the presidential task force. And so what we did, what the committee did, was to have 8 thematic areas to work on. There were about 17 members of the committee, and then supported by the ministerial staff. So we had the epidemiology and surveillance group, we had the laboratory and testing group, we had the logistics and health technology group, we had the clinical management and treatment group, we had the research and clinical trials, vaccines and medicines. Then we have the mitigation, social and health economic impact group. Then we had the continuation of other medical services and health system strengthening, and the risk communication and community engagement. And so members were now shared into these subcommittees, themes. Some belong to 1, some belong to 2, some belong to 3. I was in 3. I was in risk communication and community engagement, and I headed the continuation of essential services and the health system strengthening. I was also in the economic and social impact mitigation. And so what we do is that we were meeting twice a week to present evidence after rapid reviews of evidence about what works and when and how. And we use a lot of input from WHO, from CDC, from African CDC, and from our local evidence also, evidence that has been generated over time, especially during the Ebola period. And so this formed the input into the evidence. And so things started working better, okay? For example, even though we had the general lockdown, by the time we were about easing off the lockdown, we had suggested, and we suggested that the lockdown should be in phases, okay, based on evidence, okay, and there were certain criteria that should be met before you begin to unlock the lockdown. So these were the things that we were actually doing, and we have continued to do that. Intermittently, we meet with the minister to make our collective recommendations, but if there are issues that come on board, we meet as an emergency to take the decisions based on available evidence, okay? Yeah, for example, when the issue of hydroxychloroquine came up, and of course we had to meet, we had to synthesize, we had to do a lot of rapid reviews to get the evidence so that we can properly advise. The issue around the use of dexamethasone and all that. And then one important thing is that apart from the health aspect, we also delved into other areas, okay? Like the palliative measures from the agri-care or food point of view, okay? And we have suggested, that such measures, such activities should be properly tracked, okay? So it's not just within the domain of public health. We also extended to other sectors. And another area which we also moved into was the logistic supply, the logistics system. Okay, and we had a lot of evidence there to make our recommendation. And then risk communication. So in fact, in risk communication and community engagement, we felt that we should go back to evidence. We have long-standing evidence that the things work from the community level, okay, and that there's need to go back and strengthen the community structures and use the community structures to fight COVID, and that is exactly what we are doing now. By then, people had not anticipated the community transmission, But we also presented evidence that with this lockdown and unlocking the lockdown, the chances are that we will have community transmission, and that's exactly what happened. One particular area which I found very interesting, in the evidence, was the area of testing. Of course, testing, surveillance, and all that evidence came from what we did in 2014. But we discovered that we are not testing enough. So if you're not testing enough, it is very, very difficult to determine the epidemiological pattern of the disease. And so we insisted that in every state, subnational level, there should be at least one testing site. And it was easy to recommend the teaching hospitals and the federal medical centers. And that as soon as we get to that level, then we can begin to think of locking down, we can begin to think of community-based management of COVID-19. So all these decisions were based on, the evidence which we also generated. And then moving forward, we thought that especially the laboratory group came up to say that we can use gene experts to begin to do our testing. So we don't really need to wait. So we can do the antibody testing using gene experts, and we already have gene experts across the country.
It's really fascinating. Yeah,
yes.
I think what's fascinating is that it's so complex, right? And public health researchers, as you and Dr. Mijumbi have both kind of highlighted, is you've had to stretch out of your domain a little bit, right? Exactly. And that's really interesting as to whether, has that been part of the complexity of navigating this really challenging time of COVID? Is for those that feel like, well, I'm a public health expert, I work in health systems, I work in epidemiology. Now you're being pulled into, like you said, logistics and agri-care and all kinds of other areas. And part of it, I think, comes back to something you mentioned earlier, BSc, was about trusting relationships and the role that really played in the Presidential Advisory Committee and in getting evidence to inform decisions. Is it really mattered who was giving the message, who was the messenger, who was trusted. And I wonder if this sometimes becomes the challenge for folks such as yourselves that are advising on COVID-19 from a public health perspective, that trust then brings you into working in other areas. And I'm wondering if we can hold that thought in terms of how you have all navigated the multiple demands on your time, in terms of your expertise, and in terms of your personal and professional lives when we get to the next question. And if I can then actually, in fact, ask Professor Samba at this point to give us your perspective, Professor, on what we've heard from Uganda and Nigeria, two countries that interestingly both suffered from histories of Ebola, but we're still tackling the COVID-19 pandemic so differently given a similar experience in the past, and so much of it depended on decision-making processes. And it would be nice to know, especially because you sit in the Ministry of Health and hold an important decision-making role, what has been your experience and Ivory Coast's experience in addressing the COVID-19 pandemic? Over to you, Professor Samba.
Thank you, Nasri. It's a pleasure to be here. As you say, good morning, good evening, and good night. I am the only Francophone in the panel, so applies for my English. It's not very well, but I try to speak. Nasri, they don't say Ivory Coast, they say Côte d'Ivoire. They don't translate. Côte d'Ivoire. Yes, they don't translate it. You know, in my position, I am the Director General of Health and coordinator of the outbreak of COVID-19. in my position, we like evidence to take decision. I take decision all the time, but I have to take decision with good information or good evidence. If I don't have good evidence, I don't have good decision. You know, when the WHO says that COVID-19 is a pandemic, we have in our country a center of emergency, and we reactive it, and we write, we draw a plan for surveillance. This plan his objective is to observe and to make decision. With this plan, we have to we detect the first positive case in our country in March 11, and after that we have a little steering committee, a very little. You are 5. You are me. You have the big boss of the laboratory in Côte d'Ivoire. We have someone from surveillance, someone from what? I have someone from the care to in the hospital, and someone to the transportation of the case. The little committee have to draw the big plan of the response, and you use evidence, you use all you can find in internet, and we read to make decision. So this plan is the little steering committee only use. We have the city in Côte d'Ivoire, the University of Côte d'Ivoire of Abidjan make some studies on the COVID, and we use this result to draw our plan. But you know, in Côte d'Ivoire, the epidemic is, you can say, in Abidjan, in the capital of our country. And I know we talk about lockdown and another measure. In Côte d'Ivoire, no lockdown. I just have curfew, because economically we can't have lockdown in our country, and the epidemic is not so hard. At the beginning, we fear, we don't know the epidemic. Everybody fear. Now you know the epidemic, you know how it's grow. So in our countries now you have no another measure. You are no lockdown, you are no curfew. All is free. You can go if you want. You just have to have a mask. In our country, everybody have to put a mask. Now I am in my office. I have in my place. I have no mask. But if I go outside, I have to put a mask. So you use all you and we say, my colleagues from Nigeria talk about the Ebola outbreak. You learn about this outbreak in our region. You know, you are of West Africa, like Nigeria. You learn about this outbreak. And in our West African region, you have a lot of outbreaks. You have Ebola, you have MERS, you have cholera, you have a lot of outbreaks. So an outbreak is not, for us, is not a real problem. We have the process to go through outbreak, and you did it for not Ebola, for COVID-19. I think we have to, so we have to say you use evidence for make decision. In my position, I don't produce evidence, but I use evidence to save lives in my countries. Thank you,
Professor. Thank you, Professor Samba. I wonder if I can follow up in that in terms of as Dr. Mijumbi mentioned, there's just so much evidence, and for decision makers, this can be overwhelming. And in Cote d'Ivoire, how have you managed with managing through all the amount of evidence that's coming to you? And what role do your local researchers play in localizing that evidence for you to use in your context? If you could reflect on that.
Okay, so in my country, we have, in all countries, we have university. The university work and produce evidence. We use it. We have a scientific committee. You use it to propose to the government to me the decision we have to take. And after me, you have the minister, and the minister you have the prime minister and the president. We have a committee, another committee with name is National Security Council. It's the big committee in my country. Is us by the president of the president. So when we have this information, you have to propose the decision to this committee. Is the National Security Council. This council have to show, to understand what you want, and to have to approve it. And now it's come a decision.
Thank you. That's very helpful. I'm wondering if it makes sense for us to go to our next topic and just pick up on some of the things that Professor Samba was saying. And I wonder if Professor Uzochukwu, I could ask you to take the first shot at this, given that you mentioned multiple roles you've had to play, and a lot of challenges of time to be able to respond timely and appropriately, but also balancing everything else in personal as well as professional lives. How have you been able to navigate this, given that there's so much being written right now, at least about burnout in the field of public health, not only in terms of health workers, but also in terms of public health professionals, and wondering whether you feel a similar experience, and whether you'd like to respond to this particular question from that angle. Over to you.
Yeah, thank you very much. It has not been easy. The Ebola, the COVID-19 pandemic has really eaten into one's personal life, even professional life. There is no day, in fact, in a week, 7 days of the week, 5 of the 7 days of the week, I'm always on one webinar or the other, at times 2 or 3. I have had to start a webinar by 10 a.m. and close by 6 p.m. So it's a lot of pressure, you know. And there are other roles which I also play. For example, I am the president of the National Association of Public Health Physicians of Nigeria. And so we have our team there also in the field, and I also coordinate that. So it's not been very, very easy. What that means is that my teaching time has reduced, even though students are also on lockdown. Okay, the universities are closed down. but you discover that we've tried to be communicating with our students, so that has reduced. Even time to do other things like writing your academic papers has reduced and all that. So trying to keep pace with all these things, is very, very challenging, especially when you begin to meet with frustration somewhere along the line. At times, some of the decisions, some of the recommendations you make, and with as a body, and you feel they are very genuine, are not carried forward. So you begin to think that you have really wasted your time, doing all those reviews and looking for evidence. So it's not been very, very easy. One area which actually has affected one is the funding landscape. So if you have a lot of opportunities to do some COVID-related research, but you don't have time to put up proposals for these things, because you require to sit down and write up the proposals. So this is one other area that is, also affecting one. And there are a lot of conflicts you still need to, you need to deal with. I'll give you one example. In trying to, we had recommended that before the country starts using rapid diagnostic tests, that there should be validation. So the Medical Science Laboratory Council is doing that validation. But the pathologists, the physicians, the clinical microbiologists, the clinical hematologists, the clinical chemical pathologists also feel that they should be part of that process. And so there is that interdisciplinary rivalry which you need to also sort out. So it's not been that smooth. Even within the Federal Ministry of Health, you have a lot of conflicting problems. The agents, the departments and agencies are doing different things. For example, in risk communications, they have this agency will have their own policies and plans. This agency will have their own policies and plans. The NCDC will have their own. We have to now recommend for harmonization and central coordination of all these things. So all these things take time. So it has really compromised one's personal life. Thank you very much.
Yeah, Rhona, I saw you really nodding your head. Do you want to jump in? We've got lots of questions for all of you. So I'll ask Dr. Mijumbi and Professor Samba to respond to this, and then we'll move to the participant questions for the both of you, so for all of you. So if you can just continue with your thinking and maybe verbalize your thinking, because I can see you nodding your head, Rhona. Go for it.
I could recognize a lot of what Dr. Benjamin is talking about, and so I won't go back to it, but I definitely agree with all of what he's saying. The only other thing I might want to highlight is what I have had, what I've experienced, but what I've also had from many people leading research teams. They're researchers, but they're also leading research teams. And, as a research leader or team leader for an organization that, saw its work double during this time, because of the pandemic and because of what we do, as explained earlier, supporting decisions and policy making, especially in urgent situations, just like, COVID-19 presented. We got swamped with, policy decision questions to support at different levels. So you have, from the central level, and then you have a district level, and all of these are urgent. None of them could wait, say, a month or, several months. However, this is when the team is also working in new and challenging circumstances. So, you've had people explain how they've got to work at home, especially during the lockdown, with young families and so many people waiting on them. So having to juggle all of that. So although again, the nature of our work is such that we work anywhere, anytime, these were sort of challenges that that were an addition to the already complex times. Having to give attention to the family, heavier work burden, but then also your service providers, say for internet, now have slow connections because they're oversubscribed, everybody's doing stuff online. So lots and lots of challenges. So as a team lead, you know that you need your team's productivity at its highest, at this point. And yet you're also aware of the challenges they're facing and you're helping them to navigate them, So finding a balance can be quite a challenge in itself, but like all teams, you need to know your team well. There are people that, are like Peter the Rock, and everyone needs one or two of these, to be able to navigate these challenging times. And I think for me, it goes back also to something you were raising earlier about trusted relationships for the, the working relationship with the policy makers. I think that what was happening in many places at this point is that researchers have not established these relationships earlier. So even the kinds of task forces that we're talking about that have some researchers, have knowledge brokers feeding into them, these are ad hoc. They're formed, these are structures that are formed at the point where the emergency has happened. And so they've not had a chance to establish relationships before that. Same thing that I'm talking about, when you don't know what team you're working with, in such a time, you're beginning to understand who is who, and it will be a challenge. So one thing that we have learned, or that we have been hammering home, is what we have always talked about. All researchers knew, before this, or all people involved in evidence-informed decision-making have had the conversation about influencing civil engagement and building trusted relationships. These are like putting credit in the bank. You will need it at a time like this. You cannot start establishing those relationships at this point because there's so much going on. The policymaker is hearing from so many sources. They don't have the time to even understand who you are if they have not known you before. So these relationships are relationships that have to be established way before this. And I think now we have a task to go back and put in place structures that we can call on at a time like this, and not sort of have ad hoc places or ad hoc, groups that we are bringing together. If you have a structure that's already in place, established relationships, established sources where they know where to get what, and they know it's already appraised, they can trust it, I think it serves a lot. And I think some of the countries that already had these in place have had a better time than others. So for example, I'll give an example. At a time when a lot of our decision making in the beginning was at high levels, and some of the district levels, the lower local government levels, actually felt they were not being supported, at least not yet. And yet they knew there was a looming, something. Anytime a COVID patient could turn up in their jurisdiction. And they were in a panic, like, okay, so what do I do? Where do I even start, And because we've been working with them already, providing evidence for other decision-making processes, they were on the phone already calling us, okay, as I wait for my ministry to tell me what is it that I can actually put in place, what can I do, and things like that. So I think these relationships and structures have to be established in very good time, because I think I can confidently say this is not the last emergency we are seeing. Hopefully, I mean, we all pray for better times, but if we're going to be realistic and plan better, I think we need to keep in mind that we will be faced with other times like this, and we need to harness, the lessons from now to create structures that can be of help in the future.
Yes, and I hope there's more credit in the bank going forward now.
I hope so.
So we only have about 10 minutes left in this webinar, and we do have questions. But before we go to the questions, I just want to provide Prof. Samba maybe one quick minute to reflect on this particular question, because you're actually sitting in the Ministry of Health, and how are you navigating the multiple demands on your time with respect to research and evidence to inform decisions, being really quick with decision making, taking into consideration what you were saying is good evidence, but how do you know it's good evidence? And on what Professors Uzochukwu and Mijumbi were talking about in terms of have the relationships that have been established with your scientific community really helped you as a decision maker at this particular point in time? Did they have a lot of credit in your bank?
Thank you, Nasri. My first job is also, that is my first job. Like Professor Benjamin, is my first job. So now, but I have no time to teach and to make research because of my new position. So I use the results from my colleagues. It's very difficult because I have no time to be together with them, to have the reflection you have to have for the COVID. But they have a little group for researcher who work on COVID, and each week they come to take me to tell me some information and some decision they think we have to take in Côte d'Ivoire. All the things that they propose, I don't agree. I choose because in my position I am political maker, not health politic maker. You know, so I have to choose the decision who can be realistic for the population or for my boss. So I have this job. I mean, it's not so easy. So like say Benjamin, it's not so easy for me, but yeah. I try to do my best in this position.
Yeah. So you have to be politically correct. It's called political correct.
There we go. There we go.
Yes. It's not so
Thank
easy.
you. I think it really drives home the point, as Dr. Mijumbi was saying earlier, is researchers really need to understand the policy-making arena to be able to influence the policy decision-making and understand the processes, which Dr. Uzochukwu knows well, working in the field of health policy and systems research, that's exactly the case. And I think, Professor Samba, you really helped us ensure that understanding is there, that it's a very complex environment, this policy decision-making. It's not easy to be a decision maker. Nobody should be envying you in that case, in terms of the headaches it must be giving you. But having the research community understand that complexity, empathize with it, and be able to engage with it in a way that is constructive is something that hopefully is part of the learning and part of the capacity that's occurred over this entire pandemic in terms of bringing researchers and decision makers closer. I'd like to invite my colleague Daniela Rodriguez to share the questions in the chat with you all as we slowly wind down this wonderful webinar. And it feels like we could have talked for so much longer. Thank you.
Thank you so much to the panelists for an excellent set of conversations. We've got some really interesting questions coming up in the chat. So what I've done is I've tried to combine things that I think are kind of relatively similar. So we had a couple of questions about different forms of evidence, and we had somebody ask about those of you who, I think Dr. Mijumbi, you mentioned the role of informal evidence, and if you could talk a little bit more about that kind of thing. And another question, and I think it's a really important one, especially in rapid decision making, is what has been the role of citizens and patients in decisions that are being taken? It would be helpful to hear from a couple of you about that. So maybe, Dr. Mijumbi, maybe you can start by talking about, you mentioned informal evidence explicitly, so maybe you can respond to that specifically.
Okay, yeah. So I did actually bring out that explicitly and probably very deliberately, because I think in a disease like or in a pandemic like that, from COVID-19, there's a lot of, and I think we've seen in some places, a lot of tendency to look at the formal evidence. What is the research saying? And forgetting that COVID-19 is more than a medical problem. You know, it's more than a medical problem. A lot of it is social, it's economic, it's it's sometimes even cultural. You know, if you think about how people have to deal with death and things like that. And so a lot of the evidence that you have to depend on will not be your usual research evidence or rigorously peer-reviewed evidence. It will be a lot of what is it that's happening in the community? What is the community saying? Because one of the things for you to be able to manage something like COVID-19 is that you have to have very good buy-in from your community. You have to, in fact, its management is very dependent on the population being able to do certain things, all your public interventions, you know, keeping the distance, the social distancing, being able to survive the lockdown. A lot of them adhering to this has to be them buying in. Now, being able to have evidence that supports certain decisions that will go into that is you understanding the community that you're dealing with, you understanding what the context is. And a lot of this evidence will not come from your published literature, but it will be that evidence that I was referring to, your tacit knowledge, things that you have learned from past experience, things that you have learned from people who manage other, epidemics and pandemics. So a lot of information that you will not find sort of written or published anywhere, but information that actually goes into this very, very informally. And you have to deliberately look for it and put it into the decision. Now, the role of citizens in decision making, I think it is something that we are still trying to see how much that has been has happened. I am not sure that it has been as much as it actually should be. One, because of the time decisions have to be made, and sometimes you actually have to make them on behalf of other people. But then there are groups, especially in my country, that have tried to incorporate that because that's what they do anyway. So in the community survey, the rapid assessment survey that I was referring to earlier, a lot of community reports are feeding into that. But also when the Center for Rapid Evidence Synthesis is contextualizing evidence, sometimes they carry out citizen panels. So now during this time, they have not been able to do that because you cannot bring a gathering, of people together to be able to say whatever. So they would consult representatives, community representatives, and get that input. So we know that, this is input that, yes, as community representatives, they might be having the voice, but we haven't had that chance where you now bring, town hall meetings and be able to get input. And I think that it's been a very difficult time to be able to do it.
Thank you so much, Dr. Mijumbi. Maybe I can turn to Professor Samba. You mentioned your committee is quite small for making decisions. And you mentioned even that you have your colleagues coming to your office and saying, here's some evidence that I think you need to be thinking about. How have you worked on thinking through the involvement of citizens and patients in the decisions that the directorate is taking?
So sorry, Daniela, I don't understand all you say. So you
but I was asking it.
You can speak slowly for me.
Yeah. Yes. How have you in Cote d'Ivoire thought about incorporating the inputs of citizens and patients in the decisions that you make around COVID?
Thank you. Now I understand what you want. I think we have in Cote d'Ivoire a society. Society, right? Civil society. We work with them, and we have a lot of group of civil society. We work with them, and with the outbreak of COVID-19, we have a big meeting with them, and we have to show them the role we have to do in this outbreak. They have to sensibilize the population. They have to talk about the outbreak. We have to show the good practice So washing hand, putting mask, and all the things. In our ministry, we have a department of civil society. We work with them. We work so closely. And in the response of the country, we have a part of funding is going only to the civil society. And we have to, they say they give us the population way, they give us the hope of the population, and we have to make decision with that. So when we have the coup-free, they say by through this civil society, they can't work at night, and the government make the decision to stop the coup-free. They should work at night. If you want to encourage, they don't eat. Our population have to eat. We don't want another crisis, which is not from sanitary crisis, not a health crisis, but hungry crisis. We don't want this. So when you understand and you listen, the population up.
Thank you so much, Professor Samba.
Thank you.
BSc, Dr. Uzochukwu, I wanted to ask you a slightly different question, in particular because you raised this issue of having a task force that was being led by someone who was well politically connected and sort of the need for that, as well as then a separate committee that was more scientifically oriented. And some of the questions that are coming up here is, how do you make sure that you don't, and how do you balance between having evidence-informed policy versus policy-informed evidence? Or politically informed evidence, where you sort of collect the evidence that helps support the policy decision you already had in mind?
Yeah, well, unfortunately, we don't have control over that. And so evidence-informed policy is what we try to prioritize. But in practice, you can also witness and see, politically motivated decisions, okay, that are not based on any evidence, okay?
Yeah.
And so, but I feel that we should have a mix of that, if you must move ahead, okay? Yes. So, but we need the political buy-in, because they make a lot of the decisions, okay? Yes. But having said that, we also expect that they should use at least some of the obvious evidence to make their decisions, okay? Let me give you one example and then linking it up with what my other colleagues have said about informal evidence. In my country, people are not obeying the preventive measures. So you see people, they put on their mask on their jaws. Okay, so they said don't mix up with the crowd and all that. But they keep on doing that. The churches are open, the mosques are open, people are attending burials and all that. Do you know the reason? The reason is that the citizens have lost trust in government. So they don't believe. In fact, there are a lot of people, even well-educated people, that still don't believe that COVID-19 is real. They think that the government is just playing politics with COVID-19. So it's a big problem. And, as soon as we saw that, we had to recommend that there should be intensive community engagement and risk communication, okay? So these are some of the things, even among health workers. Some health workers have also lost trust in the government.
Yeah.
Okay. Some health workers have exposed themselves, and the government is not interested in protecting them. So all these things, these are informal evidence which we should be able to use to make decisions. Thank you.
Thank you so much for your really candid remarks on these really sensitive and topical issues. I think now we're going to shift back to closing out the webinar. I wanted to thank all of our panelists and ask us all to turn off our video for the moment, just so that we can see the slides more clearly. Thank you again so much. And for those of you who didn't have your questions answered thus far, we will make sure that we get back to you after this. Thank you so much. Nazreen?
Thank you, everybody, and thank you for joining. I'm sorry we have gone a little bit over time, but you all had some great questions, and unfortunately, we haven't gotten through to them all. However, I'd like to just inform you as we're wrapping up that both the Africa Evidence Network and Health Systems Global have important conferences this year that you might be interested to attend. We've got the information on the slide here. They're both virtual, and so they're going to be extremely innovative in the way that they are proceeding. And I encourage you to learn more from these two websites. And I think we'll have them in the chat for you to click on as well. One is Evidence 2020 Online, and the other one is the 6th Global Symposium on Health Systems Research. We have some links here if you'd like to learn more about the AEN or the Evidence to Action Thematic Working Group. We also have a dedicated page to evidence-informed decision-making in Africa with respect to COVID-19 in English as well as in French. So please do peruse these websites and please contribute to them. If you've got anything you'd like us to post on this website, please do. Please share with us. We'd be more than happy. And lastly, I'd just like to say thank you so much to all of you for joining us, to our panelists for their very candid and insightful remarks. And we hope that we will have another webinar soon on a different sector to share with all of you. Thank you and have a wonderful day. Goodbye, everybody.
Goodbye.
Thank you and goodbye.
Bye-bye. Thanks.